Good afternoon, everyone. Good afternoon, everyone. Good afternoon. I am Tom Jenney. I'm the Arizona Director of Americans for Prosperity. We welcome you all this afternoon to our panel discussion on the proposed Medicaid expansion here in Arizona. We hope to have a panel of 6 people. Unfortunately, it's only 3. We have 3 very good people on this panel. We hoped it was going to be a panel of 6 people. We cast the net rather widely. We sent invitations, and we can verify this by email and by certified letter, to Mr. Chuck Coughlin and his associates. And we've sent letters and emails to the governor's office and to all kinds of people who are promoting the Medicaid expansion, including the Access Director. And we did not get anyone to take the bait and come debate us. We offered them an equal number of panelists, half the room of audience members, and a co-moderator. And we still didn't get anyone to take the bait. So you can just file that away in the interesting file. But we do have a fantastic panel here, and I think we're going to give you a good show. We're also going to try to give these guys a workout. So if you've got any questions or you want to poke holes in the anti-expansion argument, we welcome you to please do that during the audience Q&A. And I'm going to do my best to try to poke some holes in their arguments as well. And I think without very little further ado, we're going to just launch into Michael Cannon's presentation. And I just want to say, first of all, that we're very grateful that Western Free Press, westernfreepress.com, is going to put this video together and put it on their website. We're very grateful to them, and we're also very grateful to the Goldwater Institute for allowing us to use their space and to use their policy analysts in this matter. But our first speaker is going to speak against the Medicaid expansion is Michael Cannon of the Cato Institute. Michael?
Tom, thank you to Goldwater and Christina and Jeff for being here. I think I'm going to do Marco Rubio. I should keep that open. Yeah, I better do that because you don't really know where else to put it. I'm going to talk in sort of general terms about the Medicaid expansion. There are a number of points I want to hit, and I look forward to taking your questions afterward. Those points are that the Medicaid expansion is not affordable, it's not fair, it is not effective, it's not economic development, it's not popular, and it's not healthcare reform. So each of those in turn. It's not affordable. You'll hear a lot that this Medicaid expansion is free money or something really close to free money. The federal government's covering 100% of the cost but of course it's not. The federal government under current law is supposed to cover 100% of the cost of covering one group of people, 100% of one part of the cost of covering one group of people and only for 3 years. There's a lot of the cost of this Medicaid expansion that is going to be funded by the state. The estimates that I've seen are on the order of the low billions over 10 years, maybe 1, maybe 2, maybe 3 billion over 10 years in Arizona alone. So this is not free. This is going to cost the state, and it's money that the state doesn't have. Now, there have been those who have proposed using the magic of provider taxes to pay for Arizona's share of this. In fact, I've been mentioning something that I think is worth emphasizing. I think it was in her State of the State address that South Carolina Governor Nikki Haley said that the federal government is offering us $9, and all we have to do is put forward $1 in order to get that $9. But that offer doesn't mean much if we can't afford the $1. And that's the position that a lot of states are in right now. So Arizona here, I think it was some of the healthcare providers who came up with this idea. Look, tax us, we'll pay for that $1. It sounds like they're making a contribution. They're really not. This is a scam. This is a form of Medicaid fraud called the provider tax scam. Now, to be candid, it's perfectly legal, but it's still fraud. The way it works is the state gives $1 to healthcare providers. That draws down maybe 9 matching dollars from the federal government, and then the state taxes back its original dollar from the healthcare providers, and magically this hasn't cost the state anything. They got those 9 federal dollars for free. The problem with that is, first of all, that it's fraud. the way Medicaid is supposed to work is the state is supposed to put forward some of its own money, so it has some skin in the game. And the provider tax scam lets the state get around that part of the Medicaid program. But it's also not a scam that can last. Christina knows more about this than I do, but nearly every deficit reduction proposal that Congress has put forward, that anyone has put forward, involves getting rid of this provider tax scam because it drives up Medicaid spending, and it is not going to last. If Arizona does that for a year, does that initially, they'll maybe get away with it for a year, 2 years, and then the full cost of Arizona's part is going to hit. And it's going to be even higher than what current law suggests because the federal government is going to renege on that $9 to 1 ratio. The federal government is facing a $12 trillion, it has racked up a $12 trillion national debt. It is running deficits, annual deficits in the neighborhood of $1 trillion. And it has received one credit rating downgrade. It's suing the people who gave them that credit rating downgrade, but they still might get another one. That intimidation, form of intimidation might not work. And so the federal government's going to run out of money, and when they do, they're going to push more of the cost of the existing Medicaid program and this expansion onto states. President Obama has already endorsed this idea. He sort of backed away from it for the moment because he wants to get states on the hook before reintroducing that idea, but that idea will come back and states will have to pay for more of this. So this is not free, it's not affordable. It's not fair either. Now, one of the arguments you'll hear for Medicaid expansion comes from Governor Brewer, and some others have made it, that it would be unfair for Arizona taxpayers to have to pay for this Medicaid expansion in other states without seeing any of the benefit themselves. For one thing, about more than a dozen other states aren't expanding Medicaid, so it's not like all states are doing this. But there might be a kernel of truth to this argument. If the federal government were paying for its share of the Medicaid expansion with current tax dollars, with tax revenues raised from current taxpayers. But they're not. They're paying for it by borrowing. Every penny the federal government spends to expand the Medicaid program is going to add to federal deficits. And every penny the federal government doesn't spend, because states are refusing to implement the Medicaid expansion, is going to reduce federal deficits. So what does that mean? Well, it takes that fairness argument and completely flips it on its head. It means that fairness dictates that you not expand Medicaid in Arizona, because by doing so, you would be forcing future generations to pay for a program that benefits current generations, and that is completely unfair. In addition, now there's I think a fairness argument to be made that it's unfair to hospitals, particularly rural hospitals, and maybe other healthcare providers who might be facing cuts under the Patient Protection and Affordable Care Act. Medicare cuts or cuts in payments to hospitals for the uninsured. And you know, there really is some truth to that. But the problem there is not that Arizona might not expand its Medicaid program. The problem there is how the federal government is running the Medicare program, running the Medicaid program, what it did with those programs through the Patient Protection and Affordable Care Act. And so the lobbyists for the healthcare providers who want to expand Medicaid, they have a legitimate gripe, but they're facing the wrong state, or they're facing the wrong Capitol building. They need to turn around and face the U.S. Congress and direct and have their grievances redressed there. And I think that state officials should join them in demanding that Congress reform those programs. The solution to the problems that these healthcare providers are facing is not to hurt future generations. It's not to impose taxes on those future generations who aren't even here to debate whether or not their taxes should be increased. Expanding Medicaid is not effective. You'll hear that. In fact, I was in a debate actually a hearing in Florida when an expert on the Patient Protection and Affordable Care Act said, you'll save lives if you expand Medicaid. And it makes intuitive sense. Healthcare saves lives. You throw a bunch of money in healthcare, presumably you would save lives. It surprised you to know that there's scant reliable evidence that Medicaid has any impact on health. There's been only one reliable study in the past, how long has Medicaid been around? How long ago was 1965? 40-some years. On the effect that Medicaid has on health. That study began in 2008. Congress didn't even bother to get the first year the first batch of results from that study before they went ahead and expanded Medicaid by spending another $1 trillion on it. But what that study found was that compared to people who got no health insurance, the people in Medicaid, they reported their health was some modest improvements in self-reported health, but 2/3 of it came just after they won the lottery that gave them Medicaid coverage before they received any health care. So that really calls into question really whether it improved their health. More importantly, the study found no discernible effect on mortality. So the most reliable study that's been done shows that they can't make that claim that Medicaid's going to save lives. We don't know what Medicaid does. We don't know what we're getting for the trillions of dollars we're spending, so you can't say that Medicaid is an effective way of either improving health or saving lives, and you definitely can't say that it's a cost-effective way of doing so. In other words, if you had the $1 trillion sitting that Congress wants to spend on this Medicaid program sitting in front of you, there's zero evidence to suggest that Medicaid is a better way of improving health than spending that money on discrete programs to provide highly effective services to at-risk populations like hypertension to low-income, treatment of hypertension to low-income people, or even better education. That could deliver better health outcomes. One of the reasons I think that Medicaid is not an effect, is you can't make the argument that Medicaid is an effective use of tax dollars is supporters of this law have estimated that if you expand Medicaid, 82% of the adults who enroll under the expansion are people who today already have private health insurance. And you'll be pulling them out of private health insurance into the Medicaid program. And what's going to happen once they get there? Well, Medicaid is notorious for providing inferior access to care compared to private health insurance. And there's an example of that that comes from Maryland. Has anyone in this room who's not on the dais here, has anyone in this room ever heard the name Diamante Driver? Mean anything to you? It should. It should mean a lot. If you're interested in Medicaid, you should know the name Diamante Driver. Diamante Driver was a young boy who lived in Maryland. In 2007, he was 12 years old, and he had a toothache. He had an abscess. And his mother tried to find, his family was eligible for Medicaid. His mother tried to find a dentist for Diamante and Diamante's brother, who was also complaining of a toothache. Their mother was unable to find a dentist who would take Medicaid. Only 1 in 6 Maryland dentists do because Medicaid pays so little. While she was trying to find a dentist for her boys, Diamante's I used to be able, before my son was born, I could get through this story. The infection, the abscess became infected. The infection that began in Diamante's mouth spread to his brain, and by the time he got medical care, and Medicaid ended up paying $250,000 for multiple brain surgeries for Diamante, he died at age 12. He died at age 12 from an infection that could have been prevented with a simple tooth extraction if he could have just gotten a dentist who would accept Medicaid coverage. When you think of Medicaid, when you think of the government guarantee of access to care that Medicaid extends to people, think of Diamante Driver. Medicaid is not economic development. Sure, you'll get more economic activity if you get those 9 federal dollars pouring into the state. Just as you'll get some benefits if you run up your credit card. But as I discussed earlier, the benefits from that will pay the salaries of lots of people in the healthcare sector, but the benefits are highly questionable, and you'll be taking those dollars away from probably more highly valued uses. So expanding Medicaid is not economic development. You'll hear a lot about how people want to expand Medicaid because not expanding Medicaid would threaten jobs in the state. Well, first of all, Medicaid is not a jobs program. Medicaid is supposed to be a health care program, and that's the basis on which you should be evaluating spending money on Medicaid. And as 2 Harvard economists pointed out in the New England Journal of Medicine recently, They said, quote, treating the healthcare system like a wildly inefficient jobs program conflicts directly with the goal of ensuring that all Americans have access to care at an affordable price. And just in case you were unconvinced, remember, this is a law that itself is going to eliminate 800,000 jobs, according to the Congressional Budget Office. If what you're concerned about is jobs, then I think what you want to do is put pressure on Congress to reopen this law so that this law will not end up eliminating 800,000 jobs. Expanding Medicaid is not popular. Never mind the polls that tell you that the PPACA overall is unpopular. Look at the Medicaid expansion. In Florida, a group called the James Madison Institute just released a poll yesterday that, to my knowledge, is the first poll that actually asked people about both the benefits and the costs of expanding Medicaid. Most polls just say, hey, do you want to expand Medicaid? Lots of federal dollars involved. And if you only ask about the benefits, then people will say, yeah, we want free stuff. We want to give health care to low-income people. But if you ask about the cost, you get a different picture emerges. James Madison Institute asked, would you want to expand Medicaid if it meant higher taxes, or would you want to keep Medicaid the way it is and have taxes stay where they are? 59% of respondents said keep Medicaid and taxes where they are right now. When you ask them if Medicaid would crowd out private health insurance and lure people from private health insurance into the Medicaid program and reduce their access to physicians, 65% said don't expand Medicaid. So this is not, this expansion is not popular, and it's not reform. Medicaid doesn't do anything to make healthcare more affordable. It just shifts costs, it doesn't reduce them. And if you expand Medicaid, you're going to cement our current healthcare sector's existing pathologies in place, and that is not reform. So, thank you very much, and I look forward to your questions.
I wanted to lob a few questions at Michael before we go any further. So couldn't people on the other side, Michael Cannon, say, okay, we've got these problems in Medicaid, doctors are avoiding Medicaid patients or putting them on the back burner. Isn't that an argument for trying to effectively raise the reimbursement rate by taking the federal money?
Taking the federal money won't raise those reimbursement rates. If you, is this on? No. Okay, and if you want to raise the amount that Medicaid pays to doctors, then the expansion will cost even more. Not just the expansion will cost more, but the existing program will cost more. And but I think that the whole question is misguided, because you have to understand Medicaid payments to doctors as sort of the result of competing forces in the political system that create this equilibrium of low payment rates for doctors in Medicaid. You've got, on the one hand, advocates for the Medicaid program and Medicaid enrollees to the extent that they vote. They might be putting political pressure on the state legislatures to increase Medicaid payments. You've got pressure coming from the other direction from competing uses of funds and people who want low taxes. And uniformly, throughout the country, what ends up happening is the equilibrium is that Medicaid pays very little. And so we could sit here and talk about what if Medicaid increased the amount that it pays doctors, but unless you're doing something to change the political dynamics that create that equilibrium, you could bump up the payments for 2 years as the Patient Protection and Affordable Care Act does, but that's not the equilibrium. Those prices are going to return to the political equilibrium that the political dynamics create. That's inherent in a program like Medicaid. It's always going to look that way.
Yeah, this reminds me of the old joke about losing money on each unit, but making it up in volume. And you kind of wonder what the hospital's long-term gain is. Okay, so another question for Michael. Okay, we hear a lot about reducing the FMAP. We hear about, and it does look like it's going to be put down to about 90% by 2019. And we hear a lot of people talking about reducing it further, and Governor Brewer's concerned about that, so she's tried to set up this circuit breaker thing. But one of our intrepid reporters down at the Capitol told me, well, Medicaid has never pulled back yet. And you could say, okay, that's the same thing with these complaints about the provider tax fraud, is, okay, yeah, everybody in Washington sort of kvetches about this thing, but are they actually ever going to do anything about it? is it possible that they won't pull back on the provider tax fraud, and that they won't pull back on the FMAP?
Well, there's a great quote from the economist Herb Stein. He said that if something cannot go on forever, eventually it must stop. What the federal government is doing by running up more and more debt cannot go on forever, so eventually it must stop. We don't know if what is going to stop that from happening. We don't know how it's going to stop. We don't know if it's going to be political pressure, political resistance to more deficit spending that finally gets Congress to cut things. Certainly, there's been some movement in that direction with the I guess Tea Party caucus in Congress saying no, we're willing to consider not raising the debt limit and that sort of thing. And the sequester, I think, is another example of that. Or you could have a crisis. You could have a crisis where people downgrade, credit agencies downgrade U.S. sovereign debt. The cost of it goes up much. The cost of borrowing goes much higher. People don't want to borrow federal dollars, and you could get a Greek-style debt crisis. So the answer is no. It can't keep on going. Although certainly Congress is going to follow the path of least resistance, and as long as that path of least resistance is keep on borrowing and pretend like forever is never going, or this can go on forever. I don't know when it's going to happen, but it can't keep on happening. And there are signs that it will stop happening soon.
Because long-term interest rates are. Because this is
Because
the
we've already had one
macroeconomic.
downgrade.
The other side's going to say, look, on the macro side, if Arizona is the only holdout, $2 billion in federal money is a rounding error. So why can't we just take the money? We are probably not going to be the tipping point that pushes long-term interest rates into the stratosphere.
Well, one problem with that is that, first of all, it's immoral. That's one reason not to do it, is because it's immoral to tax people who aren't even here to complain about it in order to pay for a Medicaid expansion. Another problem with it is that if everyone does that, then the crisis is going to be much worse and it's going to come much sooner.
I have a question for Mike. Could I ask a question?
Yeah, feel free to jump in.
I'm just sitting here as I'm listening to this, the bed tax thing, and I'm thinking if I'm the federal government, this gives me an opportunity to think, well, if the hospitals are willing to basically take 9, give 1 back in order to get the 9, then they don't really need 9. They really need 8 because they've already taken a 10% cut. I'm just thinking if I was the guy writing a check for the federal government, I'm thinking this could be an opportunity to say, well, you clearly don't need what we're paying you because you're willing to give 10% of it back to the state in the form of the bed tax. So maybe we can therefore give you less.
Except
Right,
the formula is probably
if they say, what the feds would say is, you're not putting forward that $1 that you're supposed to put forward, so you're not getting the 9. And that would be eliminating the bed tax and the provider tax scam. But there's another way to do it, which is you just change the ratio from 1 to 1 to 1 to 8, or there are a number of ways that they can do this, and they have a really good justification for doing it by getting rid of provider taxes, because that is a scam. It's fraud. And they'd be able to say to the states, what you're doing is fraudulent, and so we're going to put an end to it. This is good government. Yeah, the federal government would be saying that, which would be abused.
Yeah, I actually want to jump in real quick on this too. First of all, to say that Arizona would be the only holdout is incorrect. 16 of our sister states have said no. We advocate that we should join them. It's a fallacy to say that Arizona would be the only one. So when you're talking about, what's the phrase they use, $1 billion here, $1 billion there, pretty soon you start talking about some real money. It's not often that a state legislature has a veto over billions of dollars of federal spending. We do here, and we should use it. I would also point out that with the provider tax, it's not true to say they've never cut back. They've cut back twice before. They did so once in the mid-90s and once in the early 2000s with some truly egregious abuses of it. So they have done it before, and there are proposals on the table to do it again. And I'll be talking about some of that a little bit later.
It may be very soon, in fact, because our next speaker is Christina Corriere from the Goldwater Institute, healthcare policy analyst, and she gets her 10 minutes of fame right now. And then I'll try to launch some questions at you, and then we will open it up very widely to the audience, I think after we get all 3 of you through the mill. So, Christina Corriere.
I'm a little shorter than Michael, so I have to So I'm going to talk about Arizona's specific issues with the Medicaid expansion. The question that we have to ask regarding whether or not Arizona should take this optional Medicaid expansion is very simple. It's, can Arizona afford it? And to answer that, we need to know how much this will cost Arizona, not just in the short run, but also in the long run. And the simple answer to that is hundreds of millions of dollars. And according to the governor's office, the cost to the Arizona General Fund for the first full year of implementation is $154 million. Now that's stunning, considering that for the first 3 years, the proponents like to tell us it's free, right? The federal government's going to pay 100% of the cost for the newly eligibles. But that's not quite accurate. They're only going to pay 100% of the medical cost for the newly eligible. They are not going to pay for the increased administrative cost of adding thousands of new people to the Medicaid rolls. Not only that, the administrative costs are reimbursed at a much lower rate than even the Medicaid cost of our current enrollees. The other thing that it's not going to pick up is it's going to pick up at the lower rate, if the enrollees that are new, they've previously been eligible, but for whatever reason didn't sign up. They call that the woodwork effect. So with these two minor exceptions, you're already looking at $154 million during the free period. So the logical question would be to ask, how much is it going to cost after the free period, when Arizona has to start chipping in more? That starts in after 2016. They're going to drop it down until it reaches 90% at 2020. The problem is we don't know the answer to that. The budget projections that were released by both the governor's office and by the Joint Legislative Budget Committee stop at 2016. They stop after it stops being free. It's very interesting that that's where they chose to leave it off at. I think that's a question we should all be asking our legislators. How much will this cost later? I think it's also important to remember that virtually no government program ever costs only what it's expected to cost. The costs are almost always higher. And all of this is a best case scenario. There are many possibilities that can drastically increase the cost to the state of Arizona. First, the federal government could reduce the amount that it's willing to pay for the medical expenses of the newly eligible enrollees. Second, the provider tax could be eliminated or severely limited. And third, the circuit breaker that the governor has proposed might not work. So let's take those one by one. First, the government could reduce the share it's willing to cover for the medical expenses of the newly eligible. Obamacare promised the states for the first 3 years they'll pay 100%. After that, it decreases over a period of 4 years to 90%, where it's supposed to remain in perpetuity. So you might ask, or as Tom Jenney did, what makes us think that they might reduce it? It's very simple. They've already proposed doing so. Obama proposed reducing it in the past 2 budgets that he submitted to Congress. He suggested replacing the promised rates with what's called a blended rate. The blended rate was supposed to save the federal government $100 billion over 10 years. So what's Arizona's share of that? An additional $200 million. Now, to be fair, the administration did say in December that they're backing off that idea. But when you have a looming debt crisis in Washington and entitlement programs eating up a bigger and bigger portion of federal spending, it's more than logical to think that they're going to go back to an idea that they've already proposed multiple times and that they've already vetted. And in fact, the governor's office thinks that they're going to do that. The governor's office released a publication in January 2013 that's available on their website entitled Difficult Choices, Expanding Adult Medicaid Coverage. And it stated, quote, "It is probable that at some point the federal government will choose to reduce reimbursement rates to the states as a consequence of its own fiscal challenges." You need only look at another promise of federal funding to know that federal promises of federal dollars are often fool's gold. In the Individuals with Disabilities Education Act, the federal government promised to pay for 40% of a state's excess cost of educating children with disabilities. You know how much they pay today? 17%. It's less than half. This expansion could very well go the same way. The second issue is the provider tax. It's not the panacea that some people would have us believe. The governor's office has stated that it intends to offset any cost to the state by imposing a provider tax on hospitals. As you heard from Michael, the provider tax is basically a shell game employed by states to draw down additional Medicaid dollars from the federal government. Basically, Michael's explained the process to you, so I won't go over it again, but it has been described as a form of legal fraud. An FAQ on the governor's website states that the provider tax, quote, "allows for hospitals to assess a reimbursable fee upon themselves." It tells you right there, it's going back to them. Previously, Washington has twice taken note of egregious uses of the provider tax and took action to curb them. And the provider tax is under increasing scrutiny today by both sides of the aisle, by both houses of Congress, and by the president. I'll go through a little bit of it. The Democratic Senator and Majority Whip Dick Durbin called the provider tax a bit of a charade. Republican Senator Bob Corker called for a 10-year complete elimination of the provider tax. During last summer, the summer of 2012, Speaker of the House John Boehner and Senate Minority Leader Mitch McConnell sent a letter to the president requesting a reduction in the provider tax. He actually one-upped them and suggested that they cut it even further from 6% down to 3.5% to save the federal government almost $20 billion. And the Simpson-Bowles Commission described the provider tax as a gaming tool employed by states to draw down extra federal dollars and recommended its complete elimination to save the federal government $50 billion. With the potential elimination of the provider tax or significant limitations to it being discussed with growing frequency in Washington, the state could be left without a means of funding the expansion. So the logical question is, will the circuit breaker protect this? The answer is no, it won't. The circuit breaker is tied to a completely different issue. The circuit breaker is tied to the reimbursement rates for the newly eligible. The complete elimination of the provider tax, while it would leave a huge budget hole for the state of Arizona, will do nothing to turn off the expansion for us. Instead, the state's going to be sitting there looking at a very expensive bill, and they will have the choice: raise taxes, drastic cuts to other programs, or kicking thousands of newly eligible people off of Medicaid. It's going to be a difficult choice for the legislature if they have to face that. Another potential wrinkle in the proposed plan to fund the expansion of the provider tax is Prop 108. Arizona voters in 1992 passed Prop 108, which was enshrined as Article 9, Section 22 of the Arizona Constitution. This proposition required a 2/3 vote, a supermajority of both the State House and the State Senate, to impose any new tax or new fee, or to raise an existing tax or fee. Now, there is a narrow exception for fees or assessments that are authorized by statute but are not prescribed by formula, amount, or limit, and are set by a state agency. The proposed Medicaid expansion rests on this narrow exception by allowing an unelected bureaucrat at the Department of Health to levy a provider assessment to the tune of hundreds of millions of dollars. What's interesting about this one is while the assessment might not be specifically listed in an authorizing bill, everybody knows exactly what that amount or formula is. It's listed in the governor's budget. It's listed in the expansion plan. It was mentioned in the state of the state. We know exactly what that dollar amount is. So if legislators attempt to pass authorization for a provider tax on a simple majority vote, not only are they circumventing the will of the voters in the Arizona Constitution, they risk potential litigation on the issue of whether the provider fee actually meets that narrow exception. Finally, although the governor's office promises a circuit breaker, which will automatically end the Medicaid expansion if the federal reimbursement rate drops below 80%, please remember that there is nothing in politics that is automatic. There is no way to tell who will be sitting in the governor's office or the state legislature at the time that a circuit breaker might kick in. So you have to ask yourself whether or not you trust them, unknown them, to turn it off at that point. I would also point out that the circuit breaker doesn't kick in until 80%. Well, the federal government was supposed to fund 90%. We're basically allowing them to double the cost to the states before we react in any way. I would also point out that a few years ago, when Arizona froze the Prop 204 population, there was a media firestorm of stories, personal stories about what would happen to these people who were frozen, people who couldn't get onto Medicaid at this point. You're going to have that same outcry, so you have to trust that an unknown legislature and an unknown governor is going to have the backbone to stand up in the face of that. I would also ask you to recall a quote by President Reagan that government programs once launched never disappear. Actually, a government bureau is the nearest thing we'll see to eternal life on this earth. Governments, once they expand entitlement programs, they do not cut them back. While all these points are important when discussing potential Medicaid expansion in Arizona, there's one additional point that has to be made. All the proponents like to point to this free federal money. But the thing is, there is no such thing as free federal money. It's tax money. yours, mine, and every other Arizonan's, and borrowed money that has to be paid back. I would also point out that any money we draw from the provider tax money too, that has to be paid back. As states get more and more funds from Medicaid, the federal government must either tax more or borrow more to pay for this increased spending. By agreeing to the proposed Medicaid expansion, Arizonans would not only be committing the state to new spending in reliance on shaky federal promises and an uncertain funding mechanism, they would also be committing current and future Arizona taxpayers to billions and billions of dollars in new federal debt, making every legislator who votes for it complicit in Washington's spending problem. I want to make two other Arizona-specific points. They are arguments that we've heard in support of the plan. One is the uncompensated care. We're told by proponents that there's a hidden tax of $2,000 that people who are employed basically pay by having this extra money to cover the uninsured. First of all, the left-leaning Kaiser Family Foundation debunked that. The second question that I would ask you is, when we expanded Medicaid voluntarily by a bigger expansion with Prop 204, did anybody see their premiums go down by $2,000? Did you see them go down by $2? It didn't happen before, and it's not going to happen again. This is a complete fallacy. On the question of Arizona jobs, we're told this is going to bring thousands of new healthcare jobs to Arizona. I took a look at the job statistics from the Bureau of Labor Statistics, government source, when we did our last expansion to see if we had an increase in healthcare jobs. You know what we found? Not only the increase in healthcare jobs was less than half of what it had been for every year for the previous 10 years. So what is going to make them think that this expansion is going to be any different?
Thank you, Christina. I'm going to try to lob a few questions at you and see if we can get anywhere. Tom Bellock, who's the director of Access, was testifying before the House Appropriations Committee the other day, and he kept talking about how if we fail to expand Medicaid, we will be taking $2 billion out of the economy. It's sort of macroeconomic argument. Now, I understand that wasn't quite right. It wouldn't be a question of taking $2 billion out, but it would be a question possibly of not showering this economy with $2 billion of Bernanke dollars. Doesn't that have a cost?
I don't think it has a cost, and I would also point out that every one of those dollars is a borrowed dollar. It adds to the federal debt. Those are net negatives to our economy. The day of reckoning might not be around the corner, but it's coming, and every cent that we add to the federal dollar will make it, to the federal deficit, will make it worse.
Okay, what about county hospitals? I mean, this is a tough situation for them. Federal government's cutting back on disproportionate share funds, which of course help hospitals that deal with large segments of disproportionate shares of low-income people. You've also got a situation where, according to the statistics that Howie Fisher gave me, something like public hospitals have something like 13% of their costs are uncompensated care. So that's higher than your normal uncompensated care costs. Isn't this a big struggle for counties? Yes,
it's a struggle, and they should be upset about it. I think what you have to point out, though, is the state didn't create this problem, the federal government did. The federal government passed a law called EMTALA a couple decades ago. This is a law that requires hospitals to provide uncompensated care. They have to provide emergency room care to anyone who presents to stabilize them through whatever it is that they're experiencing, regardless of ability to pay or citizenship. This was a federal law. This is what created that problem. And the federal definitions are so broad that somebody can present at the emergency room with, a minor cut or a cold, and they're going to have to treat them. So yes, this is a problem. This is something that needs reform, but the reform needs to come at the federal level, not the state level. So the federal government created the problem. It's the job of the federal government to fix the problem. It's not the responsibility of Arizona to take on massive amounts of new spending to fix a federal problem.
I was going to say, we've got people in the legislature, in local county situations saying, okay, yes, I agree, the feds created this problem, the feds need to fix it, but while we're waiting for the feds to fix it, shouldn't we just take the money?
No, we shouldn't take the money, because that will be committing Arizona to enlarging a welfare benefit program that they're going to have a hard time extracting themselves from, that's going to have unknown future costs and is not going to improve care, as Michael said.
Okay, speaking of costs, one of the assumptions that's on the table of the legislature is the idea that we're going to be compelled to backfill the 204 population that was the enrollment that was frozen. And that when we do that, and the idea is that two things are going to force us to do that. One, the courts are going to force us to backfill the 204 population, and two, the HHS, the federal government, is going to we all know the waiver supposedly expires in 2014. So if we're faced with that, and the estimates are fairly large in terms of what kind of a hole this will open up in the state budget, we're talking maybe $400 million a year. And when you look, if there is that kind of a hole, it becomes extremely tempting at that point to take the money.
Well, I would ask them if they read the court cases that actually say we don't have to backfill it. There was a court case after Arizona froze the Medicaid population. A group of plaintiffs filed suit claiming that Prop 204 required the state legislature to continue to fund this group. What Prop 204 actually did was assign a specific funding source, which was the tobacco tax settlement revenue, which is not nearly enough to cover the Prop 204 population, and then they left it to the legislature to find other available funds. Well, during the debt crisis, the financial crisis here in Arizona, when the economy was so bad, the legislature determined that we simply didn't have the money, there were no other available sources, and froze the population, at which point this lawsuit went forward. In the trial court, they determined this was a non-justiciable political issue. Basically what that means is the courts cannot compel the state legislature to fund it. That's the purview of the legislature to decide what funds are available. They cannot compel the legislator to tax more in order to fund this. They can't compel them to cut other programs in order to fund this. It was appealed to the State Court of Appeals. They found the same thing. This was not the purview of the courts. This was a legislative decision, and the Supreme Court of Arizona chose not to review the case. So the case is over and closed unless they can find a new novel legal argument. And the state of the law right now is that it is up to the legislature to decide what other funds are available. So I'm not sure where they're getting the idea that they're going to be forced to fund this.
What about the HHS waiver?
The HHS waiver does run out at the end of the year, but HHS has consistently pointed to Arizona as one of the gold standards in Medicaid. It's hard to believe they would yank a waiver that would cause even more people to lose coverage. So I think that's speculative at best and doubtful to happen.
Okay, and I want to ask one more question about Prop 108. Maybe it's murky. As I understand, talking to legislators down there, the word they're getting from Ledge Council and from JLBC is that there's a strong chance that because of the little loophole that was in 108, it's perfectly possible that if we don't name a dollar amount and we don't put a specific formula on it, that this loophole could be big enough to allow the Access Director to raise taxes, essentially hospital bed taxes, by hundreds of millions of dollars a year. Isn't this something we ought to kick out to the courts? Should the state of Arizona just go ahead and do this, and then the courts will tell us if that's a violation of 108?
I don't think it's what we should do, because what will happen is if you authorize the provider tax, and then somebody files suit to say that it violates Prop 108, and the court agrees that it does, the provider tax is null. You've now already agreed to expand Medicaid. You now have those costs without the funding mechanism, and you're putting a huge amount onto the federal budget. It is better to play it safe and have a Prop 108 vote, a 2/3 majority vote, before authorizing any tax.
Okay. Thank you, Christine. Next up to speak is Dr. Jeffrey Singer, who is a surgeon here in Phoenix, but who dabbles in policy analysis as an associate fellow at the Cato Institute.
Adjunct scholar.
Adjunct scholar. We have to get these titles correct. Most importantly, this is a man who, on a daily basis, cuts into people's bodies and tries to make them better. Dr. Jeff Singer.
I'm going to probably be guilty of apostasy here because most of my colleagues have been receiving frantic emails from the hospitals in which they practice, urging them to contact their state representatives and tell them to support Medicaid expansion, and all of the hospitals who have high Medicaid patients. Patient populations are doing the same thing. And so if I was in keeping with the majority of my peers, I would be putting my own immediate short-term considerations to get paid ahead of what I consider to be the good of the future for not only Arizonans and Americans, but my kids and my future grandchildren. So for that reason, I'm probably an aberration among my peer group of healthcare providers by arguing against Medicaid expansion. Not only from the fiscal standpoint, as has been ably outlined by the previous speakers, but as a doctor, I can tell you from personal experience that Medicaid is not the best way to increase healthcare outcomes for the indigent. It's the worst way. In my own personal experience as a surgeon, I've had numerous occasions where I've seen patients who came to me very late. I deal with colon cancer, among other things, and I've had patients come to me at a very advanced stage, and I'm kind of alarmed because by the time I see them, I know I can't do anything curative. I can only hope to do something palliative, and I learn that they've actually it's been taking about 8 months to get to me because of the whole long, delayed track they had to follow. First to get into a primary care doctor, then to get referred to the gastroenterologist was killed a couple of months, then to get endoscope was killed a couple of months, and by the time they see me, it's kind of late in the game. That's happened often. Or, for example, when I have to do breast cancer surgery and I need to work with a plastic surgeon to do a reconstructive surgery after a mastectomy, and there's only 1 or 2 in the entire metropolitan area who accepts Medicaid, and it gets really hard to get this thing accomplished. Sometimes I've had patients say, forget it, never mind, let's not do it. Just do the mastectomy and I'll pass on the reconstruction, which is certainly suboptimal. It's not just my own experience. There's been a lot of good studies in the medical literature to back this up. And I don't want to sound like we're here at a medical conference, but I'll just cite a couple of medical journals articles. In 2011, the American Journal of Cardiology reported on a study that showed that Medicaid patients are 59% more likely to die of strokes and heart attacks after getting an angioplasty, than patients with private insurance, and twice as likely as people who didn't have any insurance at all. 2011 Journal of Heart and Lung Transplants, Medicaid patients are 8% less likely to survive head and neck cancer surgery than private or uninsured patients. Heart and lung transplants. 2010 Journal of Head and Neck Cancer Surgery, Medicaid patients are 50% more likely to die and 80% more likely to have spread than private patients. And similar findings have been found in patients on Medicaid who have breast cancer, colon cancer, and other recent studies. There was a really big study done that was reported by the University of Virginia. It was reported in the Annals of Surgery. They examined 900,000 cases from 2003 to 2007 of major surgeries, and they compared Medicaid versus private versus uninsured outcomes. They found Medicaid had the longest length of stay of the 3 categories in the hospital. Medicaid patients were twice as likely to die in the hospital than private insured patients, and uninsured patients were 25% less likely to die in the hospital than Medicaid patients. By the way, all the studies that I've cited, the researchers controlled for the socioeconomic and cultural factors that could negatively influence the health care of poor patients on Medicaid. Now, a great deal of these poor outcomes has to do with the fact that there are, because of the poor payment to providers, it's hard to get people into a provider. There are shortages of providers willing to see Medicaid patients, or providers keep a kind of a quote on how many they will see in a given period of time because they can't afford to see too many. And now, other studies that back this up, just this past March 2012, in the Journal of Health Service Research, Chapin and White reported that Medicaid may reduce access to health care. A 2011 New England Journal of Medicine article showed 2/3 of Medicaid children were denied doctor appointments versus 11% of those with private insurance. And then back in 2007, I think Michael alluded to this, Jonathan Gruber, who was one of the architects of Obamacare, and I think he was also one of the architects of Romneycare, he of MIT and his colleague David Rodriguez, they reported in a paper for the National Bureau of Economic Research that doctors doctors get lower fees for Medicaid patients than from the uninsured. And I could tell you that's true. I could tell you as a private practicing general surgeon, when I have an uninsured patient come into my office and say, what is your fee for this? Would you accept some sort of payment plan? I love that. I wouldn't mind if all my patients were like that, because in many cases I get paid better than people with regular insurance as well. Now, it's interesting about this whole mantra that the cost shifting from uncompensated care is this hidden tax, which I can tell you just from what I just explained to you right now about taking care of uninsured patients is not true. That's really a total myth. There have been a number of studies that have shown that uncompensated care amounts to something like less than 2% of all health care costs. And it's much more complicated than just being shifted over. So for example, like I say, sometimes patients who don't have health insurance, they pay, just because they don't have health insurance doesn't mean they're not willing to pay for health care. Now, Gruber and Rodriguez's study dealt with that subject actually. They said, quote, our best estimate is that physicians provide negative uncompensated care to the uninsured. They are earning more on uninsured patients than on insured patients with comparable treatments. And they wanted to say even our most conservative estimates suggest that uncompensated care amounts to only 0.8% of revenues, or at most $3.2 billion nationally. These results highlight the important distinction between charges and payments and point to the need for a redefinition of uncompensated care in the healthcare sector going forward. Now, all these studies that I've referred to deal with Medicaid in the United States in general. Arizona, to be fair, Access, which is the name for Arizona's Medicaid program, has actually a much better track record than Medicaid in a lot of other states. They are less micromanaged, less bureaucratic, and in many cases they actually pay physicians better than do the Medicaid programs in other states, comparably speaking. And Access will boast that their outcomes, in comparison to Medicaid outcomes in other states, are superior. And there's no denying that, but we're still dealing with Medicaid. So you still, even if they pay doctors and hospitals better than Medicaids in other states, they still pay them lower than doctors and hospitals would otherwise get, and that's why they're having trouble getting enough providers willing to participate in the program. Another downside, of course, of Medicaid is that since there is no skin in the game for the Medicaid beneficiary, because they don't have to pay anything out of pocket, there tends to be overutilization. I think, I know for a fact, Michael was talking about this one study that was done in Oregon, and it was called the Oregon Health Insurance Experiment, and it began, they started the experiment in 2008. This is actually really good evidence-based research. They took 10,000 patients and they randomly divided them into Medicaid and non-insurance, and they're following them long-term, so it's a prospective study. And what they found so far at the first year's data report was that consumption rose, although interestingly, the first 6 months of the existence of this program, consumption didn't rise, which would kind of speak against the idea that there's a whole bunch of pent-up care that people haven't gotten, and once they get Medicaid, they suddenly start using this care they need. It took about 6 months to kind of ramp up. They also found that there was no discernible improvement in healthcare outcomes comparing those without insurance to those with Medicaid. And there was also no discernible decrease in emergency room use between the uninsured and those on Medicaid. Remember, one of the arguments that are put forth is that people go to get their care in the emergency room and they don't have insurance, and by getting them onto Medicaid, then they won't be going to the emergency room as much, and they'll be going to primary care doctors, and that'll decrease the cost of the system. But they found no difference. I could attest to that. I have this problem all the time. It drives me nuts. Because Medicaid patients don't have to pay out of pocket, they don't like to wait a lot. So, for example, 2 days ago, just so happens, I said, I got to remember this for the talk. 2 days ago, I had a patient who had an appointment to see me for gallbladder symptoms. Like I said, this is one of the things I take care of. And she's a Medicaid patient, but she couldn't get a ride. So she was already about an hour late for appointment, and we got a hold of her, and she said, yeah, I'm having trouble getting a ride. So my assistant said, well, would you like to reschedule? And she said, no, my friend's coming home from work after 5, and she's going to give me a lift to the emergency room, and I'll get taken care of over there. Now, I already know that this person doesn't have an emergency problem because she was scheduled for a consultation with me regarding symptomatic gallbladder disease. So when she goes to that emergency room doctor is going to probably, for medical legal reasons, run some tests to make sure that he doesn't miss anything because he doesn't want to get sued. So she gets another CAT scan, and she's probably already had one. She's probably had a CAT scan and an ultrasound and all sorts of blood work before she was sent to me because she was sent to me by a primary care doctor. But that's going to all get repeated. And then the emergency room doctor is going to feel comfortable enough legally to say this person's not an emergency and say, you know, you want to go contact your primary care doctor and have him get you an appointment with a surgeon, which is what's going to happen. She's going to get released, and I'll probably see her in a week or two when she can get a ride. But that kind of thing happens all the time. Or another example, I did an outpatient surgery and on a Medicaid patient. And then after surgery was over with, I went to the office to see patients, and my office is right next door to the hospital where the outpatient surgery took place. And I'm in the office seeing patients, and about maybe 2 hours later, it was a minor surgery, the patient apparently, his dressing became soiled. So, you know, we scheduled this through my office, so he knew my number. He came to my office originally. He didn't call my office and say, my dressing is soiled, what should I do? And I could have either given him instructions over the phone. I said, well, why don't you come on into the office right now? I'm here. I'll take a look at it. He went to the emergency room at the hospital, probably like 500 yards from my office. And the emergency room doctor phoned me in the office and said, you just operated on this guy a couple hours ago. He came in, his dressing was soiled. I changed it. It looks fine. I just put another dressing on and told him to see you in the office next week. And I said, well, thanks, but why did he come to you? Why didn't he just call me? He says, he's a Medicaid patient. What do you expect? That's the truth. Yeah. These kind of things happen all the time. So another thing that has to be kept in mind is that when we expand Medicaid, we're expanding health care that is at least at the level of consumption to the Medicaid recipient free. And there's no disincentive to overutilization, which of course drives the costs always way higher than the initial projections were. So, you know, there are lots of ways if we really want to help indigent care. There are a lot of proposals out there that could be debated in a separate forum. Some proposals, for example, called for just block granting Medicaid money to the states, let the states design their own systems. We have 50 competing laboratories of democracy. Systems can be much more focused and cost-effective. Just recently, Indiana experimented with a program they call the Healthy Indiana Plan under Governor Daniels, where they had a pilot project where they actually used HSAs with catastrophic health insurance for a small group of Medicaid recipients, and they found that utilization went down very well. The patients became much more cost-conscious consumers. They had to get a temporary waiver to allow that to happen. I think that waiver's been now, it's expired, or it's not going to be renewed. And we can argue about the pros and cons of all these things, but the fact is, if we want to get better access to health care for indigent populations, the way to do it isn't by putting more and more of them onto a health care program that traps them where they get inadequate care and they have incentives to actually waste money. Therefore, I'm going to break with the stereotype of my special interest group, and at the risk of their wrath, I'm going to again put the well-being of the people of the United States of America, the people of Arizona, and more importantly, the generations that follow me. I'm going to put them ahead of any immediate short-term remunerations that I can get. Thank you.
A doctor who doesn't want money. Doesn't want that extra money.
I don't want that kind of.
Okay. Thank you. Dr. Singer, and really anybody, I'll kind of open this up a little bit more generally, but if you want to have the first crack at it, Dr. Singer. And I got some help from Dr. Byron Schlomach, who's an economist here at the Goldwater Institute, and he put out, if you get their daily email, his email today, he pointed out that the governor's office and other interest groups in the Chamber of Commerce at one point are talking about uncompensated care in Arizona costing the average family $2,000 a year. And so Byron did some simple math on that, which is, if you take uncompensated care as, they're really saying $2,000 per family per year. And if you take uncompensated care, and the range right now is about 6% of total cost of health care, then you're talking about every family in this state, the average family in this state, having an insurance policy that costs $33,000 a year. And Byron's argument was that this is impossible. So my question for everybody would be, where in the world are they getting numbers like $2,000 a year? What basis in reality does that come from?
I don't know where that particular number came from. There was a similar number, a nationwide figure, that a group called Families USA, this is a left-leaning group that focuses primarily on healthcare, came up with that has been repeated by President Obama. You remember in many speeches, addresses to Congress and so forth, he said that uncompensated care increases your health insurance premiums by $1,500, I think the figure was, and that caused even some supporters of his law to say, Mr. President, no, that's not how it works. They as Christina mentioned, the Kaiser Family Foundation, which is another left-wing research group, not so much a lobbying group, they have said that the figure is actually much lower. And I think it was in the low single digits in terms of the percentage impact on premiums. There is uncompensated care, and to some extent it does impact premiums for people with private health insurance. But no, I think it's actually below 2%.
Yeah, in fact, the Urban Institute and the CBO, Congressional Budget Office, both did studies on this. It came, I think, to 1.7% of total healthcare costs.
I think the Kaiser Urban study was the same one, the same people.
And when I had a back and forth with Howie Fisher, who's a capital reporter here, he apparently there's a newer study from Urban that shows it's a little bit higher than that, but not much higher. It's still down in the low single digits.
And it's important to keep the following in perspective. There is uncompensated care from the uninsured, but there's also uncompensated care from people who have health insurance but don't pay their share of the medical bills. Yeah. And uncompensated care from the uninsured accounts for 2/3 of uncompensated care. From the insured, it's another 1/3. And these are all pretty small figures in terms of, well, they're actually big figures, but in terms of national health expenditures, are pretty small. It's all 4% total, so you're talking about 2.8% of national health expenditures is uncompensated care to the uninsured, and 1.2% is uncompensated care to the insured. And so you might be able to squeeze that uncompensated care number down a little bit. I'm not sure that you're going to be able to, but well, there's still that problem with uncompensated care from the insured. So,
and I think the argument from our side, from the center and from the center right, was okay. So you've got this tiny problem. It is a problem. It's a real problem. It's kind of like seeing a cockroach scurrying across your kitchen floor, and you throw a hand grenade at it. And the idea that going to Obamacare, taking over the entire healthcare system to solve that problem is not a very good idea.
And Jonathan Gruber, when pressed on what has happened in Massachusetts, they did the same thing. The theory was you expand health insurance coverage and you'll get less uncompensated care. He said, actually, the government ends up spending more, not less. So I mean, it's not like this is going to make the cost go.
And I'll just say about cost, this whole notion of cost shifting too is, cost shifting is a fact of life in everything. When a person is in aisle 4 at the supermarket and accidentally breaks a jar of pickles on the floor instead of cleaned up, that's a cost. And all that stuff gets shifted to the people who are buying groceries at that store. To try to have a world in which there's no such thing as cost shifting is really asking for something that's not possible.
I did have a question for Dr. Singer and anybody else who wants to pile on. But what I would ask you, so you made some good arguments that and a lot of statistical evidence from these studies that shows that having no insurance sometimes is a better deal than having Medicaid. The question is, imagine you're in that population, you've got $22,000 for a family of 4 right now, and you have a chance to get a Medicaid card. Do you say no?
Well, a lot of people
And take
do.
your chances?
A lot of people do. Isn't that what they call the woodwork effect? There are a lot of people, is it estimated another 22% of people or something like that?
Yeah, the JLBC estimates that about 50% of the people that are currently eligible but not enrolled will actually enroll next year. So there is a very large portion of people that are eligible but for whatever reason don't sign up. They don't know, or they make an active choice.
I mean, yeah, I know in my experience, this is obviously anecdotal, but I've had patients who made that conscious choice and they actually endeavor to pay. They want to, that's their, their moral way of looking at things.
My personal hedge would be to take the card, but keep it in my pocket and try to negotiate a cash rate.
You're not allowed to.
It's lower than 0?
You're not allowed to.
No, if you're in Medicaid, you're not allowed to pay for anything any service that would be covered by Medicaid. And there's a logic to that. Why do you need us to pay for this if you can pay for this?
It's effectively a single payer.
So you're stuck. Once you take that card, you're trapped.
All right, I have one last question for everybody, and this question actually came from a conversation with a legislator this morning, and I won't name him or her, but it was an interesting question, which was, hey Tom, I'm thinking about caving in on this thing and taking the money.
That's just how they put it.
No, actually, this is great. This is a very honest individual, and this individual said, yeah, you know what? This is a lot of money. They're worried about the 204 question, and the individual said, is there anything that would sweeten the pot? Is there something we can put in? Can we get a lot of co-pays for access? Could we? And so what I said was, is there something we can throw into this deal that we can get a deal with HHS, and this will make it a lot easier for us as conservatives to go in for the Medicaid expansion? And my idea, off the top of my head, was, well, if they're willing to block grant the money to us and let us do HSAs for everybody in the Medicaid population, that would cause me to scratch my head a lot and wonder if there might be a deal here. Is there anything you can think of? Anybody on the panel that would make this a palatable deal?
Well, the whole idea is to increase enrollment in Arizona's Medicaid program by how many people?
It's about 57,000.
57,000.
That's the new population.
That's
the old
the new
population
population,
is...
yeah.
And the woodwork effect is going to make it even more so. So the question is there anything that could make making tens of thousands of additional Arizona residents dependent on government for their health care and more willing, therefore, to vote for higher taxes in the future, is there anything that could make that okay? I think the answer to ask the question that way is to answer it, and the answer is no. Then when you look at the impact that it would have on Arizona's budget, but more importantly, the impact it would have on our healthcare sector and our ability to deliver low-cost, quality healthcare to everybody, the answer is absolutely no. I mean, health savings accounts are a fine way of structuring health insurance. And they're fantastic. I have a health savings account, but precisely because they're so attractive that you don't want to introduce them into the Medicaid program, because right now Medicaid as it exists provides an in-kind subsidy. Instead of providing cash, it provides goods and services, health care. If you say, all right, we're going to pare back a little bit on the health care part by giving you maybe a high deductible in your Medicaid coverage, and give you cash so you can meet that deductible, you're going to be pulling all sorts of people out of the woodwork who are eligible for Medicaid but not enrolled so that they can get that cash. So you're not going to be reducing the government's involvement in healthcare or the Medicaid rolls or government spending. You're going to be increasing all of these things. So there's absolutely nothing that HHS could throw in to sweeten the deal, to make this palatable, to make this okay. Even if they gave a block grant to Arizona, let Arizona spend those federal dollars however Arizona wanted. They can't do that. They don't have the statutory authority. They would need Congress to act. But even if HHS did have that authority, they could take that away tomorrow and Arizona wouldn't be any better off. So just even to ask the question, is there some sort of sweetener that could be thrown in? reveals that the person asking the question has no concept of how awful this Medicaid expansion is going to be for people.
Come on, man, I asked the question.
I would add,
That was someone who asked you the
That's right.
question. No, that's right. You conveyed it.
I would also add that it's the House of Representatives that authorizes spending, not HHS, so no, they have no authority, and if they think they do, they're probably gonna wind up in litigation. Second of all, I would echo what Michael said. If somehow they managed to sweeten the pot with additional federal dollars, those could be yanked anytime by any administration. And finally, I think this just illustrates the problem that so many of our legislators in so many states are simply addicted to federal dollars. It becomes a tragedy of the commons when every single legislature in every single state tries to grab as much money as they can possibly grab while the getting is good. All this does is bring forward closer and closer the day of reckoning. It will come. The sooner that legislators disabuse themselves of this notion that there is free federal money for, as far as the eye can see, the better off we will all be.
No one wants to strike a grand bargain on this thing? There is no grand bargain.
I think we should block grant Medicaid, but that's a completely separate issue beyond expanding it.
Obamacare is probably the worst piece of healthcare legislation the Congress has ever enacted. It's going to make healthcare more costly and more scarce, not the other way around. And so, the sweetener would, for me, the only thing that would make this okay is getting rid of the entire law, because that's necessary in order to enact the sort of healthcare reforms that will make healthcare more affordable, that will improve it, and bring it within reach of people who can't afford it today, and in a way that doesn't trap them in a welfare program and prevent them from climbing the economic ladder.
Okay, I've asked, I think, enough questions, and so we ought to pitch this out to the audience. If you can speak very loudly, our intrepid team from westernfreepress.com will be able to pick up your voices. And I understand sometimes they do scripts underneath if we can't, but if you can, please be as loud and articulate as you can be. And I understand that, and we'll even try microphones. But speaking of loud and articulate, we have Mr. Wes Harris from the original North Phoenix Tea Party.
Not really anymore. That's been combined. I'm now We the People Arizona, which is a constitutional lobbying movement, and that's the basis of my question. It seems to me that we're dancing around the problem, have been dancing around the problem for a very, very long time, and that's the constitutionality of the federal government being involved in healthcare in the state of Arizona at all. And that would be, to me, the issue. And it would seem to me that it's time for state legislators to stand up and say, hey, wait a minute. You guys don't belong here. You shouldn't be doing this. It's unconstitutional. We're in the Constitution. Are you given the right to do this? And we're not going to take it anymore. We're just not going to do it. And when we do that, we can then go into our Medicare or Medicaid, state administered, with our own state dollars and start setting some limits on what you can do, and do like when I was young, when I first started out and I had 2 children and everything else, I had catastrophic insurance. I went to the doctor for sniffles and what have you like that. I had to pay the doctor for that. That was 100%. And that was understood. Now, if one of my kids came down with leukemia or something else, then I had this catastrophic insurance that would cover that. And this is what Medicaid should be doing in the state, so that we don't have people running into the federal government-sponsored programs into our hospitals and saying the hospital is being mandated by federal government. How does the government get that right to mandate to our hospitals what they can and cannot do?
Well, actually, the way that they do that is it's a condition of receiving federal subsidies. And if they didn't take the subsidies, then there wouldn't be that requirement. So what you're saying is that Arizona should just stop taking the money, and I think they should. I was counseling states to opt out of Medicaid, but not just the expansion, but the whole program, even before the Supreme Court ruling made the expansion optional. Because I think you're right, the U.S. Constitution doesn't mention health care anywhere. And so that's a power that Congress just doesn't have, and yet here we are.
The way they derive that power is from the tax and spending clause. So states have the option to say no. However, if states say yes, then Congress can put strings on it. I would also point out, just because you brought up catastrophic coverage, Obamacare doesn't make that a choice anymore once you turn 30. Catastrophic coverage is only going to be available for people under the age of 30, the young invincibles, and with people staying on their parents' coverage until they're 26, it's really only available for a very, very small subset of people because the government thinks they know what kind of insurance they need better than you do. It's another offensive provision within Obamacare, and yet another reason for repeal.
And another reason why, if, for example, Arizona decided to design its own indigent care system and just provided a program where it provided catastrophic care to the indigents so that the indigents pay out of their own pocket for regular routine stuff, which I would support that idea. The problem is that a lot of the policymakers have been sold on this notion that that's not, that all of this routine stuff, this so-called wellness, is what will keep costs down. That by doing that, we're saving money in the long run. They bought into that whole thing, which has, again, not been shown. In fact, they suggest that it just increases expenditures, it doesn't improve outcomes. You know, they want us doctors to practice what they call evidence-based medicine. They don't like us to practice intuitively, where, you know, I like to do this and this treatment for a patient because, based upon my experience, I just think this is the right way. Instead, they want me to follow what the research shows and let that govern my decision-making. And of course, that makes sense. But they don't practice evidence-based public policy. They just, you know, intuitively, they say something like, you know, maybe, I think if we did, for example, electronic medical records, they decided that if we had everybody went electronic, that's going to reduce errors and save money. Nobody studied it, they just did it. So now, after all of us are being forced to go through the expense and all the inconvenience of it, a study is coming out showing, it just came out recently, showing that it doesn't decrease errors, but it does increase costs because the software helps doctors bill better.
It also increases the ability of the federal government to look at our medical records,
Of course.
they couldn't do before.
Yeah. But
We have
these things before they do a study.
We have a quick question from Representative Bob Thorpe.
Actually, I just want to give you an observation. I'm certainly not one of the people that's interested in taking the money and running. So we're going to, there's a number of us that down the legislature, we're going to stand very strong and try to defeat this. But just some of the frustrations that we're dealing with, of course, access and Medicaid is under the federal government's domain. And so when we try to reform it, try to save money, it's extremely difficult, and oftentimes the federal government overrules us. So, for example, federal government will have patients who don't have transportation take taxi cabs as opposed to taking the bus. That, if we could turn that around and save us about $50 million. I've been working with a number of doctors, including ED doctors, and for example, this one doctor was telling me they'll have patients come in for a free bottle of Motrin because they can get a prescription. So that $5 bottle of Motrin is a $300 bottle of Motrin. They'll come in for pregnancy tests when they've already taken them, and they'll claim abdomen pains. One patient was transported by ambulance because he had lint in his navel, and everything was picked up by the taxpayer. So we have a huge problem, and I completely agree with the panelists. The temptation of federal dollars. You know, who's going to stand up and say enough? Our nation is going bankrupt. So I'm one that I say enough is enough. And if we can continue down this road, we certainly need here in Arizona to have the discretion of managing these programs to the best of our ability with the goal of getting these people off the programs. I would much rather that everyone's making a terrific wage and buying their own health insurance as opposed to being dependent upon government services.
And we don't have time, so I will not tell you the story of my 93-year-old grandmother getting a pregnancy test on a routine visit to a hospital that was apparently was covered by Medicare, and Medicare had no problem with that. And so I'm going to go back over to this side, and you said you don't even need a microphone. All right. Oh, please say your name.
I'm Valerie Roller, and anybody that knows me knows I don't need a microphone. My question is that I would want to ask the representatives that are wanting to have this is who determines what 100% or a 90% reimbursement of the actual costs are? Are those the actual physical costs that it costs the state, or is what they think it should cost?
It's 90% of the medical costs, so whatever the rate is that Access pays for that.
Whatever Access pays, so maybe not the actual costs themselves.
Right.
Well, it's not costs, really. I'm an economist, and I very jealously guard the word costs. It's our word, and people abuse it all the time. They say costs when they mean spending, they say costs when they mean prices, they say costs when they mean other things. So the way it works is the federal government says if you're going to have a Medicaid program, you have to cover a certain number of people, and states can cover more people, you have to cover a certain number of benefits, states can cover additional benefits, and then the states set the prices for each of those services that the state's going to pay for. And then however much money the state puts forward to cover all of the services that those people get at those prices, the federal government then matches how much the state pays. So the prices are controlled prices. They're price controls. They have little relation to costs. And so the spending is determined by those factors, and that's how that emerges. It's all a political process instead of a market process. So you get all sorts of ridiculous misallocations, and we've heard about some of them.
My question, maybe for Michael, what will it take, and when do you think it will happen for Obamacare to implode?
Well,
Excellent question, I think.
there are a couple different ways it could happen. I'll give you the best case scenario and the worst case scenario. The best case scenario is that Oklahoma's Attorney General or some other similar plaintiff wins their lawsuit against the Obama administration, and Congress reopens the law and repeals it because they see it'll implode before it even takes effect. Now, why would Oklahoma's lawsuit do that? Because under the statute, if a state does not create a health insurance exchange, as Arizona has not, and as 33 other states have refused to do, then that refusal to create an exchange blocks major portions of the law without which the whole regulatory scheme cannot operate. I don't think it can operate anyway, but without those parts of the regulatory scheme, and I'm talking about tax credit subsidies, the employer mandate, and to a large extent the individual mandate, without those in place, everyone's going to know that this thing is going to blow up. And if it happens, if that happens before it takes, if everyone sees that that's going to happen before it takes effect, then Congress is going to have to do something about it, and hopefully that thing is repealed. Why the lawsuit matters is because under the statute, states have already blocked, 2/3 of the states, 34 states, have already blocked all those provisions. So if the Obama administration were following the law, Congress would be debating repeal right now. But the Obama administration is not following the law. The Obama administration is trying to impose those provisions in states that are exempt under the statute. States that Congress exempted from, say, the employer mandate tax. The Obama administration is trying to impose that tax in those 34 states, including Arizona, with absolutely no congressional authorization, contrary to statute and congressional intent. Oklahoma is saying you can't do that. They took them to court, and so if Oklahoma wins, then that's best case scenario. Congress sees, oh my God, this is going to blow up, and they reopen it and hopefully repeal it. The worst case scenario is this. Oklahoma loses, or that money goes out the door, starts going out the door on January 1st of 2014, and once the money starts going out the door, it's going to be really hard, if not impossible, to cut off that revenue stream. And so over time, what happens with Obamacare is its high costs cause a consolidation in the health insurance industry. Its perverse incentives force insurance companies to deny care to people. People blame the insurance companies rather than the government that created these problems. Dissatisfaction with the insurance companies rises. There are fewer and fewer health insurance companies due to a number of dynamics in the law. And there's so much dissatisfaction with private health insurance, the government says, you know what, we need more competition in the market. We're going to offer a public option. Then that public option uses the advantages that it has because it's a government plan to drive the remaining private insurers out of business, and you have single pay. That's the worst case scenario because it doesn't have to implode rapidly. We can slowly turn up the heat on that frog and he won't jump out of the water until he's cooked. No, then he can't. But if Oklahoma wins, then we turn up the heat immediately, and the frog jumps out, and we can get rid of this thing.
As, I guess.
And I should mention, I'm sorry to interrupt, ma'am, but I should mention, there's no need to put all of our eggs in the Oklahoma basket. Arizona could file a similar lawsuit today to stop the Obama administration from spending $500 billion without congressional authorization, because it's $500 billion that they're planning to spend, and taxing Arizona employers without congressional authorization. The state could file that lawsuit, employers could file that lawsuit, individual residents could file that lawsuit.
Why don't
You live in Arizona, you tell me.
Or can they join Oklahoma's lawsuit?
They could. A Texas employer has asked to join Oklahoma's lawsuit, but again, no sense putting all your eggs in that basket. The more lawsuits, the merrier.
The thing is, if you get a circuit split, where one circuit court says, no, this is illegal, and another says, yes, it is, you increase the likelihood that it goes to the Supreme Court.
But I'm sorry, ma'am, I interrupted.
No, that's fine. I just have a couple questions, comments. Number one, why couldn't Arizona allow Arizona insurance companies to sell across state lines and possibly help reduce, to get a broader base to, absorbing the costs? And, because I know I'm paying close to $4,000 for a $5,000 deductible right now, $4,000 per year with no copays. And, that's what I chose because I keep myself healthy. I'm 60 years old, so, but I wish more people did that. But I've also done, so that's one question. And I've done worksite benefits at all sorts of employer locations across the valley, as well as in other states, and at both healthcare as well as non-healthcare facilities, employers. And I've actually had employees say to me, well, we'll buy the health insurance for ourselves, but we're going to put our 2 or 3 kids on access. And when it only costs them $50 per month to pay for the dang health insurance for their kids. Oh, and by the way, they say, and I'm not going to have to, they don't have to pay a copay on access, And so basically, it's like there's so much fraud in the system right now. To let more people in to the system, it is just absolutely mind-boggling to me.
Arizona could vote tomorrow in the state leg if they wanted to allow insurance companies from other states to compete in Arizona. Generally, states don't do that. I favor it because I think the more competition you have, the better. One thing I would point out, I don't think doing so would be as helpful as it was prior to the passage of Obamacare, because before you had some states that were really, very liberal states decided that insurance companies needed to cover all kinds of expenses. Arizona chose not to have a lot of mandates. That kept our prices down where it drove others up. Some states shortened the amount of age band rating that you could do, meaning that younger people were charged more to subsidize the care for the older people. Arizona didn't do that. Arizona did a lot of things right that kept our rates low. However, Obamacare basically made insurance a one-size-fits-all proposition for the entire country. So you're not going to have a lot of choice in what years we'll cover. So while I still think it's a good idea because more competition is always better for the consumer, I don't think you're going to get a lot of difference in prices, especially after the rest of Obamacare kicks in January.
Also, the legislature did pass, was it 2 years ago? A bill that allowed Arizonans to buy insurance across state lines, and the governor vetoed it.
Yeah. You have a very strong lobby from domestic insurers here who don't want to compete with out-of-state insurers.
Yeah, my brother, let's see, Bruce Springsteen lives in New Jersey. He has insured his voice with Lloyd's of London. He's bought voice insurance from Lloyd's of London. My brother, who lives in New Jersey, can't buy health insurance from Pennsylvania because that's illegal. So I agree that it'd be a fantastic idea. Unfortunately, it's not going to make any sense with Obamacare on the books because there's no variation regulation from state to state that would allow you to achieve some savings. As far as the Medicaid fraud question, You haven't even scratched the surface.
Oh, I know.
I mean,
know, believe
the
me.
official estimates of fraud in Medicaid posit that there's like $50 billion a year in fraud or something like that. In some segments, 40% of Medicaid spending is fraud. And the experts will say that even those official estimates of tens of billions of dollars lost to fraud each year are comfortingly low and misleading because they don't even bother, it's other people's money, so who cares? They don't even bother to measure how much fraud there really is. So we find out from reporters rather than government auditors that there's a Brooklyn dentist who billed Medicaid for 1,000 procedures in a single day. That is a very hard-working dentist. Who can perform that many procedures in a single day. These stories keep on coming.
One last question over here.
With our Senators Colin McCain again pushing the amnesty bill, what impact is that potentially going to have on our discussion of cost in Arizona?
Well, I would say it's McCain and Flake now, because Senator Kyle has retired. The potential effect of that is that if there is a citizenship component to it, once they became citizens, they would be eligible for all of the same government programs as any other citizen. You cannot segregate it, which means if they are Medicaid eligible, they would be able to get Medicaid. So it would drastically change the estimates from the governor's office and the JLBC.
And might I add something? This is an important dimension of the Medicaid expansion that Governor Brewer raised. She said that one of the reasons she wants to expand Medicaid is to prevent discrimination against citizens. Because there is actually a weird quirk in Obamacare that says that legal immigrants below the poverty line will get subsidies through an exchange when otherwise identical citizens would not. Now there's a reason for that. They thought that everyone was going to expand Medicaid to cover all those citizens below the poverty line, but some states don't cover legal immigrants through Medicaid, so they're going to cover them through the exchanges. The quirk is, though, that legal immigrants get those subsidies, citizens don't. So Brewer said, well, we have to expand Medicaid so that we're not discriminating against citizens. And that has it exactly backward. First of all, it doesn't eliminate the discrimination because the subsidies for the exchanges are for private health insurance, which provides better access to care, so that the immigrants are still getting a better deal than the citizens are. But Governor Brewer already solved that problem because those subsidies are the subsidies that are available through health insurance exchanges. And if Arizona refuses to create a health insurance exchange, then under the statute, those subsidies cannot be offered through a federal exchange. Through the federal exchange that the government may or may not create and operate in Arizona. So she's already taken care of that problem. That's not a rationale for expanding Medicaid. The problem right now is that the Obama administration is trying to offer those discriminatory subsidies here in the state without congressional authorization. So if you're concerned about that kind of discrimination against citizens, what you need to do is you need to file the sort of lawsuit that I was talking about that Oklahoma has filed to block the Obama administration from offering those illegal subsidies, those illegal and discriminatory subsidies, without congressional authorization.
We wanted to thank everybody. We've reached our time limit on this. We want to thank westernfreepress.com again for doing the video on this. If you want to know more about Americans for Prosperity, go to americansforprosperity.org. Please go to goldwaterinstitute.org, and please go to cato.org. That's C-A-T-O, and you can get in contact with all of us, and we'd love to talk to you about how to reform healthcare for the better in America. Thank you.